So the frequency and the clinical relevance of low-burden mutation remains to be explored prospectively in larger series of patients, and that was the rationale that prompted us to undertake the NEXT-IN-CML study, a multi-center, multi-laboratory prospective study aimed to assess the feasibility, cost, turnaround times, and clinical utility of an NGS-based BCR-ABL kinase domain mutation screening approach. The NEXT-IN-CML study involved 4 labs and 39 hematology centers all over Italy and was meant to consist of 2 consecutive phases. A first technical phase aimed to create a network of labs sharing a common NGS protocol for BCR-ABL kinase domain mutation screening and an optimized pipeline of data analysis. And also it was aimed to assess the accuracy and interlaboratory reproducibility of results to make sure that all the 4 labs were aligned and producing concordant results. Then the subsequent phase of the study, recently completed, was aimed to prospectively apply NGS in parallel with conventional Sanger sequencing in a consecutive series of patients. 211 were the TKI therapies, so the usual cases in which we should be performing a mutation screening, and to correlate NGS results with baseline disease features, previous therapy and levels of response at the time of sampling, but also to the response to subsequent therapies and 12 months outcome, and we are currently collecting the follow-up data. The NEXT-IN-CML studies, the final results of the NEXT-IN-CML studies will be presented at the next ASH meeting. I'm gonna give you some snapshots of these results. So during the phase B, as I mentioned before, we analyzed in parallel 211 CML patients, and patients positive for any mutations were 42 by Sanger sequencing, 20%, and 94 by NGS, 44%. NGS could detect low-burden mutations, and the definition of low-burden mutations in this case is mutation greater than 3%, because I had no time to tell you that at the end of phase A, we realized that 3% was the most conservative lower detection limit to ensure reproducibility and exclude false positive or PCR artifacts. So patients positive for low-burden mutations detectable by NGS only were 52 among those negative for mutations by Sanger-seq, but also 24 patients who were positive for mutation by Sanger sequencing turned out to carry additional low-burden mutations detectable by NGS only. And here you can see the breakdown of low-burden mutations according to their resistance profile. So 8 patients had the low-burden T315I, 43 patients had a low-burden mutation known to confer resistance to imatinib, dasatinib, nilotinib, or bosutinib other than the T315I, and the remaining 25 patients had only mutations with an unknown resistant profile. No IC50 data available, no previous reports in the literature. So overall, a total of 76 patients had low-burden mutations detectable by NGS only, so 36% of our series of patients, and 24% had the relevant TKI-resistant mutations that were missed by conventional Sanger sequencing. So you will be hearing at the next ASH meeting the full set of data. However, the conclusions that can be drawn from this NEXT-IN-CML study experience is that robust and reproducible NGS-based BCR-ABL kinase domain mutation screening can successfully be implemented in national diagnostic lab networks and is feasible with turnaround times and costs comparable to those of Sanger sequencing. In a large prospective series of CML patients with failure and warning, known imatinib, dasatinib, nilotinib, or bosutinib-resistant mutations were missed by conventional Sanger sequencing in 24% of the patients, and that low-burden mutations Low-burden TKI-resistant mutations in particular were found to be sufficient to drive clonal expansion. We have patients with follow-up analysis and follow-up data, and we saw that if the TKI was not changed, this mutation came out. Whereas more data are needed to understand the clinical significance of those mutations with an unknown resistant profile. So currently, the best available options for NGS-based BCR-ABL kinase domain mutation screening in our laboratories are either using Illumina MiSeq or Ion Torrent PGM. The mini-seq and the NEXT-seq, both from Illumina, have the drawback of smaller amplicon length. They can both produce reads of 250 base pair maximum, which is too small for BCR-ABL, especially if we want to look at the clonal asset. And the Ion S5 from Ion Torrent Thermo Fisher is a little bit big. Both Illumina MiSeq and Ion Torrent have an adequate read length, and if we use the NanoKit region or the Ion 314 chip, respectively, we have the right throughput to analyze 12 to 24 samples in a sequencing run with quite a good cost effectiveness. We are currently using Illumina MiSeq, and we have calculated that the approximate cost per sample is around 75 euros, the wet lab cost, considering reagents and plastics. So the standard of care today for BCR-ABL kinase domain mutation screening still is conventional Sanger sequencing at the time of failure warning. But I believe that NGS at specialized reference labs should gradually replace Sanger, again, keeping the same setting in which BCR-ABL kinase domain mutation screening is recommended, failure and warning. But how to interpret the NGS results? So if we perform NGS in the adequate settings, we will be facing 3 different scenarios. Here you can see scenario number 1 and scenario number 2. We may be detecting with NGS low-burden clinically actionable mutations like this low-burden T315I here, or this low-burden nilotinib-resistant mutation here. I do believe that these mutations should be included in the therapeutic decision algorithm. On the other hand, there may be cases reflecting scenario number 3, in which we may be detecting low-burden mutations of unknown clinical significance. These mutations, at present, we have no evidence that they should trigger a therapeutic change unless, of course, failure is observed. What are the remaining challenges for using NGS for routine BCR-ABL kinase domain mutation screening? The lack of international guidelines. Still the guidelines talk about conventional Sanger sequencing. Also, the high throughput of these sequencers mandates centralization in few reference labs for cost effectiveness. Resistant patients are not so many. Commercial panels that include ABL1, and as you know, almost all the myeloid panels from different companies do include ABL1, but they are not specific of BCR-ABL1. I would like to stress this point. So we still need to stick to custom assays, generating amplicons by nested RT-PCR, and to use custom pipelines of analysis. This is a big hurdle if you want to stop this assay. And also the possibility of using duplex sequencing or error-corrected sequencing is not yet routinely applicable, especially in the setting of BCR-ABL where we have to use a custom assay. So there are commercial companies like NimbleGen, QIAGEN, or Agilent that are providing this kind of commercial kits for each and every gene you want. But if you need to start from RNA, like for BCR-ABL, it's still a big complication. And that was my last slide, and I would like to thank you for your attention.